Все есть, да? Она переходит, все переключается. Все, спасибо. Hello, dear colleagues. Let's begin our lecture. Today's lecture's topic is a chest trauma. On this picture, you can see results of different chest traumas. Usually, it's very severe problem, severe traumas with polyorganic injury. As you know, in chest cavity localized heart, lungs, mediastinum with different organs, and of course magistral vessels, big magistral vessels. Of course, injury of these organs is very important and very dangerous. As you see on these pictures, severe patients for ICU department with a lot of hematomas on chest cavity. Sometimes it can be combined injury on the chest cavity and abdominal cavity too. So, chest trauma can be blunt and can be penetrating. Knife or any foreign body injury of the chest cavity. Incidence can be sudden and dramatic, directly 20-25%, usually 1 in every 4 traumas, deaths. Contribute to 25-50 of the remaining deaths. Usually in the United States is about 16,000 deaths per year. Care. Improve pre-hospital and perioperative care. More patients getting to relief. Many die after coming to hospital. Death possibly preventable. Of course, by promptly diagnosis and therapy treatment. History. 3,000 years ago, treating gladiators' chest injury. 1635, de Vaca, removal of arrowhead from chest wall. 1814, Leray reported injuries to subclavicular vessels. 1902, Hill performed first cardiography in United States. 1934, Blaylock, first Americans to successfully repair an aortic injury. On this picture, you can see boundaries of the chest and little information about anatomy. Superiorly, localized clavicles, inferiorly diaphragm, laterally rib cage. Anteriorly, localized sternum, posteriorly vertebral bodies and ribs. Structures injured. It can be any organ in chest potentially susceptible, especially to penetrating trauma, of course. It can be heart, lungs, vessels, aorta, vena cava, heart, esophagus, and other organs. Contents of thoracic cavity: chest wall and ribs, lungs and pleura, great and thoracic vessels, heart and mediastinal structures, diaphragm. Also, there are localized esophagus, thoracic duct, tracheobronchial system. Also, in the risk presence other organs like thoracoabdominal injury. In case of thoracoabdominal injury, it can be any wound below nipple in front and inferior scapular angles dorsally, may result in intra-abdominal injury. It can be knife, it can be gunshot also. Also in the risk is the peritoneal viscera, liver, spleen, stomach, colon and small intestine, biliary system. And also retroperitoneal system, space, kidney. Results of the injury: rib fracture, sternofracture, open and closed pneumothorax, unilateral or bilateral, hemothorax, presence of the blood in pleural cavity, pneumothorax, it's presence of the blood and air in thorax cavity. Also can be pneumomediastinum, presence of the air in the mediastinum. Pulmonary contusion is hypertension of the pleural cavity. Myocardial contusion, hypertension in myocardial cavity. Diaphragmatic rupture, rupture of the diaphragm. Here you can see on this picture subcutaneously emphysema. When it can happen, usually it can happen in case of rupture of lungs or injury of lungs. Usually it will present in case of rib fractures, and by this rib fracture any traumas, fractured rib traumas of the lung. Then as a result air from lungs go to the subcutaneous tissue and patient then will look so. Here, subcutaneous emphysema. Clinical conditions. It's related to mechanism of injury, location of injury, associated injury, comorbidities. Mechanism of injury, of blunt injury, is mostly managed not operatively. Simple intubation we use and ventilation. Chest tube placement. But by the way, I want to tell you that in case of blunt trauma, sometimes of course we can use and manage it non-operatively, but sometimes by blunt trauma can happen any complications of this trauma like bleeding, like crush syndrome or something else. In this case, of course, we also need surgical treatment. In case of penetrating trauma, it can be low energy, medium energy, and high energy. Low energy, impalements or knife wounds, disrupt only structures penetrating. Medium energy, bullet wounds from masked handguns, primary tissue damage, then high velocity force. And high energy from rifles and military weapons, shotguns, low velocity. Transfer kinetic energy to tissue, it gives cavitation and as a result high velocity. Amount of tissue managed proportional to amount of energy exchanged between the penetrating objects and the body part. Pathophysiology, of course, it's quite serious. Hypoxia and hypoventilation is the main result which can happen in case of chest trauma and chest injury. Primary acute killer of trauma patient. Inadequate delivery of oxygen to tissues. By the way, now in the COVID period, COVID times, main, of course, result of this viral infection is the inadequate delivery of oxygen. It's very low saturation of the oxygen to the tissues, and due to this thing happens so a lot of complications of COVID infection. And in case of injury, chest trauma, of course, is mechanical trauma, and it's mechanical cause of the inadequate delivery of oxygen to tissues by any trauma, any rupture of the lung tissue. Signs of hypoxia: increased RR, change in breathing pattern, excess behavior, poor air movements, diaphoresis, dilated pupils, cyanosis, usually as a late sign. Inadequate intravascular volume. It can happen due to blood loss. If we have injury of lungs or injury of any vessels, it can also be combined or simple bleeding. Bleeding from lung tissue, bleeding from magistral arteries and veins, bleeding from the heart, from the pericardium, and due to blood loss will be inadequate intravascular volume, and of course in decreasing of BP. Ventilation and perfusion mismatch, contusion, hematoma, alveolar collapse. Changes in intrathoracic pressure relationships. Here can be two main complications. It's tension pneumothorax and open pneumothorax. Also present one more type of pneumothorax is closed pneumothorax. But tension pneumothorax is much dangerous for patient because in case of penetrating trauma, usually can happen entering of the air from the environment to the pleural cavity. And in this case, when air can go in and can go out, it called open pneumothorax. In case when with every breath in and out, air enter inside of pleural cavity, but cannot go out due to tissues of the wound which doing function of the valve, like a valve working. So air with every breath in can go inside of pleural cavity but can go out, and with every breath in and breath out, this air increase, accumulate in pleural cavity. And this type of pneumothorax, it's called tension pneumothorax, and of course is a main dangerous case in this in so patient when we have tension pneumothorax and can be collapse of the lungs. And of course we should do first aid, and our management is change tension pneumothorax to open. Metabolic acidosis, hypoperfusion of tissues, and can be shock as a result. Management, of course, in chest trauma main, and this patient of course is for ABC reanimation, and of course this patient for ICU departments, because usually it's very severe, very hard traumas with massive bleeding, with any hypoventilation complications and hypo volume, BP decreasing. That's why we're doing primary survey, most important features of chest injury evaluation. Aim to identify and treat immediately life-threatening conditions. Early interventions geared towards identifying, correcting, and preventing problems. So problems like tension pneumothorax, massive hemothorax, open pneumothorax, cardiac tamponade, and flail chest. Resuscitation of vital functions. Please remember that most life-threatening injuries is treated by airway control and chest tube every time. Detailed secondary survey, influenced by mechanism of injury, high level of suspicion, may show simple pneumothorax, hemothorax, pulmonary contusion, myocardial contusion, blunt aortic injury, rib fracture, and diaphragmatic rupture. Definitive care, usually, of course, it's operative. Adjuncts, chest X-ray, basis for initiation other investigations. Of course, usually we first of all use chest X-ray. Why? Because we try to confirm any traumas of the ribs, rib fractures. When we confirm rib fractures, we try to confirm any disposition of these fractured ribs. Because if this fractured ribs is dispositioned, so we have high risks of the complications like rupture of the lungs and bleeding and pneumothorax, of course. All wounds to thoracic cavity bounded back and front by neck and umbilicus for stabs, neck and pelvis for GSW. Must have chest X-ray, upright if possible. After when we perform chest X-ray, also of course we can use additional investigational procedures like ultrasound of pleural cavity. Due to this procedure, we can find any accumulation of fluid. This fluid can be blood. Also, by chest X-ray, we can find any accumulation of the air in pleural cavity. Also, by chest X-ray, we can see disposition of the sound lung, left or right, due to trauma. Disposition, it can be collaborated. Also, and if we see this picture, and if we see trauma, and if we see air in pleural cavity, so we can think about tension pneumothorax. Also, we can use focused abdominal sonography for trauma or hemodynamically unstable blunt traumas. Patients usually use it. But ultrasound we can use not only for this patient, for all any traumas, chest traumas, we can use ultrasound. First of all, to find any accumulation of fluid and blood, in pleural cavity. Secondary, to check abdominal cavity problems, because a lot of cases when this trauma can be combined, abdominal thoracic, and we can find and we try to find and confirm or cancel traumas of cell organs like liver, spleen, diaphragm, accumulation of any fluid or blood in abdominal cavity. CAT scan also we can use. CT of angio vessels, becoming a primary diagnostic tools. We can use fast spiral, allow for reconstructions. Also, this procedure we use, but main of course, usually it's X-ray and ultrasound. Specific chest injuries. In chest wall, it can be refraction. Most common sign of blunt chest injury, it's fixed scapula, first rib, sternum suggests massive force of injury. First and second rib fractures is associated with serious other injuries. Why? Because as you know, in this area localized subclavicular veins and arteries. That's why it can give massive bleeding. And upper ones is a suspect vascular injury. On this picture, an X-ray and intraoperational picture you can see here, case of refraction. You can see asymmetry here, first of all, of the chest of patient. X-ray, you can see fractures of these ribs. And intraoperationally, we can see after thoracotomy. Signs and symptoms. First of all, you will see deformity of the chest wall. Also, will be localized pain, tenderness, and sometimes crepitation in case of the fracture, refracture with rupture of lungs. Treatment. First of all, we give analgesia to prevent any traumatic shock and pain shock. Pulmonary toilet, we do first surgical aid of the wound and observe for possible pneumothorax. How to do it? Chest cavity X-ray, and then management depends on the cost. Flail chest. It's a segment of chest wall that does not have continuity with the rest of thoracic cage. Usually 2 fractures per rib in at least 2 ribs. Segment does not contribute to lung expansion. Disrupt normal pulmonary mechanism. Accompanied by pulmonary contusion in 50% of patients with flail chest. Pathophysiology of flail chest. Main problem is the injury to the underlying lung. And of course it will give pulmonary contusion. Signs and symptoms of flail chest. Dyspnea, chest pain, paradoxal chest wall movement, poor air movement, crepitus, hypoxia, cyanosis. Treatment: pain control, humidified oxygen, close observation for respiratory decompensation, aggressive pulmonary and physical therapy, selective intubation and ventilation, significant other injury, respiratory rate more than 35, where oxygen is less than 80, where CO2 is more than 66. Other treatment is a tight fluid resuscitation. Operative fixation not usually required historically. It depends from a lot of individual points. It depends on the cause of the mechanism of trauma. That's why operatively, usually now we can use exactly metal osteosynthesis, fixation of the fractured ribs, but we doing it usually in that case when we have dispositioned fractured ribs. In case when we haven't this disposition and haven't any complications of rib fracture like pneumothorax, bleeding, injury of lung, we can don't do any operation and use just conservative treatment. It's analgesics, anti-inflammatory drugs, and elastic bandaging of the chest cavity. Pneumothorax or hemothorax must treated with simple tube thoracotomy. Usually we do pleural cavity puncture in this case. First of all, of course, we're doing chest X-ray, and when we an ultrasound, and when we identify any presence of air or blood, which can be fluid on X-ray or on ultrasound, but it can be blood, of course, we have indications for pleural cavity puncture. And usually this puncture we will do in different points, depends on the cause, pneumothorax or hemothorax. Pneumothorax less than 1 to 2 centimeters may be observed in otherwise healthy patients if stable or few chest X-ray 6–8 hours after. Open pneumothorax. Open sucking chest wound. If opening 2 or 3 of the diameter of trachea, air will come through wound. Preferentially allows free passage of air into and out pleural cavity. As a result, effective ventilation impaired and hypoxia and hypercarbia. Signs and symptoms: penetrating chest wound, decreased breath sounds, sucking sounds of Inspiration. Treatment. 3-site occlusive dressing. Observe for tension pneumothorax and operative treatment. But usually, before operative treatment, we use pleural cavity puncture. And in case when it pneumothorax, usually we're doing puncture in second intercostal space by midclavicular line. And in case of hemothorax, we're doing this puncture in 6th or 7th intercostal space by posterior axillary line. Why it's different? Because physical rules is anything, everything. By the physics, all air go to the upper parts of the lungs, and that's why we should do our puncture in second intercostal space. If it blood or any accumulation of the fluid, usually is 6 and 7 intercostal space, because fluid by physics is go to the lower parts. Tension pneumothorax. One-way valve allows air leak from lung or chest wall, and as a result, air forced into chest cavity without escape. And this most dangerous without escape, so will be increasing of the pressure in pleural cavity. It can give collapse and collaboration and collaborating lung, of course. On this X-ray, CT scan, you can see collapses ipsilateral lung. Here you can see displaces of mediastinum to opposite side, also due to tension pneumothorax. Compresses opposite lung by also tension pneumothorax. Here decreases venous return. Signs and symptoms of tension pneumothorax: hunger, chest pain, respiratory distress, tachycardia, hypertension, tracheal deviation, absent breath sounds, hyperresonant percussion, and GVD. Treatment of tension pneumothorax: immediately decompression, and is first and main. You should do immediately decompression. Large bore needle, second intercostal space, midclavicular line, chest tube as definitive treatment, of course. But if you see that this happens in the street and you haven't any needles, any equipment for adequate medical treatment, of course you try to use anything which you have now. It can be any tube. Simple pen can help patient. You just take tube from the pen and enter it to the wound to open the valves, to open the way to the air evacuation. If you see that patient is very cyanotic, the respiratory insufficiency is increased, patient can have any air and can breathe in, you should do it. It's first aid, of course. Of course, if it happens or patient admitted to the hospital, of course you have everything, all equipment to do it. First you're doing X-ray, confirm presence of the air, then you're doing pleural cavity puncture. Note, in this case, may mimic a collapsed lung on the other side. Trachea deviates towards the collapsed lung. However, one resonant empty, other tympanic. And on this picture you can see how we're doing, where we're doing it anatomically. So you palpate clavicula, behind it first rib, second rib you palpate, and between second and third rib in this bimiclavicular line. In this point, you're doing this puncture. And here in this picture, you can see how we can do it. But usually, we use, this is simple syringe. Usually, we use special syringes for pleural cavity puncture. Pulmonary contusion. The largest of the patient are those with blunt trauma. Most common chest injury in children. Usually develops over 24 hours. Can occur with or without laceration of parenchyma. Results from leakage of blood and fluid into interstitial space of lung. Significant inflammatory reaction to blood components in the lung. Pathophysiology of pulmonary contusion. Loss of normal lung structure. Function lead to poor gas exchange, increased pulmonary vascular resistance, decreased lung compliance. And complication of pulmonary contusion is atelectasis, pneumonia, ARDC, respiratory failure. Diagnostic. Parenchymal infiltrate seen in chest X-ray, adjacent to injured chest wall. No real clinical findings, especially in Italy. Dyspnea, chest wall, contusion or abrasion, increased RR, may have crackles. Lung gets stiffer, causing dyspnea and increased RR. Blood gases worsen 2-3 days as edema increases. Chest X-ray changes may lag 12-48 hours behind. May underestimate the true extent. CT is very sensitive, can allow quantify it. And treatment. Most supportive, it's usually resolved in 5-8 days. We give for these patients usually oxygen plus observation in milder cases. Pain control to allow adequate ventilation and better management of secretion. Fluid restriction, intubation with mechanical ventilation, if respiratory distress present. Indication for intubation. First of all is a respiratory distress syndrome. Second is a comorbidities, also lung disease, other injuries, and also intra-abdominal too. Myocardial contusion. Physical bruising of the cardiac muscle. Usually, it's associated with fractures of the sternum. Any severe anterior chest injury can be cause of it. It's difficult to diagnose. Very high level of suspicion. All patients with pattern of injury must have an ECG. Diagnostic. Ectopy. On ECG will be ST elevation, tachycardia, friction rib symptom, enzymes may be normal. And treatment, monitor in ICU department and treat dysrhythmias, serial enzymes, analgesia. Massive hemothorax. Usually, pleural cavity is holds 3 liters of the blood. 201 liter in chest cavity seen on chest X-ray. 90% from internal mammary or intercostals. 10% from pulmonary vessels. Treatment is decompression, chest tube must need just that. Bleeding may stop when lung re-expands. Aortic rupture and great vessels injury. Also, it can be as a result in case of chest traumas and chest injuries. Abrupt deceleration or compression injury. Sudden motion of heart, great vessels within thorax. Great vessel injury may occur in 0.3 to 10% penetrating trauma, often rapidly fatal. Only 10% survive to hospital. Only 20% survive more than 1 hour. 90% who reach hospital will die. Early diagnostic and aggressive treatment is the best chance for patient. Signs and symptoms of aortic rupture. It's hypovolemic shock, chest wall and hemosis, marked difference in BP, fractures of first, second, third rib, especially from the left side. Diagnostic. Consider mechanism of injury. Widened mediastinum or chest X-ray. 40% normalizes with sitting up. Mediastinum is more than 8 cm wide. Blurring of aortic knob. Like in this X-ray picture, you can see it. Deviation of nasogastric tube to right. CT with contrast, then we do an angiogram if abnormal. And here you can see angiography of the coronary arteries. Treatment. Contained injury, BP control first of all, and operative repair. Cardiac injury, very high lethal, fatality rate 70–80%. Mostly it will be ventricular, right or left. Why? Because mechanism of these injuries usually it's localized to the ventriculus. Very difficult to injure atriums. Cardiac tamponade. Blood in pericardial sac. It's cardiac tamponade. Occurs most frequently with penetrating injuries. Signs and symptoms of cardiac tamponade. It's shock, first of all, of course. It's GVD, it's dyspnea, it's PEA, it's Beck's triad, majority of patient, distended neck vein, muffled heart sound, and hypertension. Treatment. Volume resuscitation, pericardial synthesis. It's puncture of the pericardium for evacuation of the blood. And surgery. Pericardial window, sternotomy or thoracotomy. 3 different ways for surgery. Diaphragmatic rupture is also one of the results of the trauma. It's traumatic herniation of the abdominal content into the chest. Mostly will be on left side. Why? Because from the right side localized liver and it's protect rupture in this area. And here on X-ray pictures you can see these changes which happens in the case of diaphragmatic rupture. And intraoperational, here you can see on CT presence of the stomach in pleural cavity You can see air and fluid. Here you can see presence, also I think the stomach. And see, here is abdominal cavity, abdominal content leading to the pleural cavity. And intraoperational picture, you can see this is diaphragm, normal tissue, and this is defect in diaphragm, rupture. Lever from right side is of course protect right side of the diaphragm. Frequent in thoracoabdominal trauma, 15% stab wounds, 46% is GSW, 15% greater than 2 cm long. Maybe no immediate herniation of abdominal contents. Signs and symptoms. No distinctive signs, symptoms seen. High index of suspicion, needed especially with mechanism of injury. Dyspnea, cyanosis, shoulder pain, vowel sound in lower chest. Up to 13 acute injuries missed in Italy. 85% presenting in 3 years as obstructions or with decreased cardio, pulmonary reserve. Goal of treatment is maintain adequate oxygenation, intubate, nasogastric decompensation of the stomach. And here you can see surgery stages of operation, how we're doing it. Diaphragm is the crucis of the diaphragm, and here you can see rupture. This is defect in diaphragm. We evacuate omentum enter to the pleural cavity, evacuate omentum from pleural cavity, and now find rupture and we'll suture it. Next problem is the esophageal injuries, most due to penetrating trauma. Diagnostic is difficult, very difficult, if dilated rapid sepsis or high mortality. Requires aggressive investigation, radiography, endoscopy, and thoracoscopy. Treatment is thoracotomy. In case of esophageal injuries, usually we can try to do fibroesophageal gastroscopy, we can try to do CT scan, we can try to do X-ray. And by endoscopy, by fibroesophagoscopy, we of course is better because we can find area of this penetration, area of the defect of esophagus. Thoracic duct injury, accompanied thoracic vessel injury, noted much later, not in acute phase. Heart morbidity due to severe nutritional depletion. Mean initially aggressive and monooperative, hyperalimentation, TPN, and if not, sealed in 5-7 days, surgical intervention. Emergency thoracotomies or acute thoracotomies we use in next cases: cardiac tamponade, vascular injury to thoracic outlet, massive air leak, endoscopic radiographic evidence of tracheal or bronchial injury, esophageal injury, chest tube output, immediate evacuation of 1,500 milliliters blood or less than 250 per 1 hour. Trend more important than initial output. Early thoracotomies, survival rates about 8%, and usually it's look so. To do or not to do? It's a very difficult question. Of course, if we have all indications for it, we should do it. Type of cardiac activity: asystole, bradycardia, and tachycardia. And on this picture you can see when we can do it, when we range of electrocardiac activity following resuscitation thoracotomy. Type of vital signs: electrical cardiac activity, palpable pulse, and recordable blood pressure. And due to this, also we have a picture when we should do it. Recordable blood pressure, of course, very high indications for thoracotomy. Location of loss of vital signs: street, transport, transit ambulance, unloading area, hallway, resuscitation area. And resuscitation area also high level. Unlikely to benefit if blunt injury with arrest, arriving without pulse or BP, penetrating injury with arrest, better chance, high likelihood of isolated or correctable intrathoracic injury, still extremely rare. Bottom line: early thoracotomy if presence of measurable pulse, blood pressure, organized cardiac activity. Must consider also age, comorbidities. Avoid if arrest occurs outside of resuscitation area or due to blunt trauma. Be mindful that circulatory arrest will give cerebral hypoxia or permanent neurologic deficits, and non-functional severe occur in 10–15% of survivors. Chest tube insertion, most common intervention, relatively simple procedure, definitively manage about 85% of the chest trauma, penetrating or blunt, has significant complication rate to 19%, may be minor but may require operative intervention and can result in death, unfortunately. Chest tube insertion indications: drain content of pleural space, air, blood, heal gastric content, prevent development of pleural collection after thoracotomy, prevent tension pneumothorax in ventilated patient with rib fractures. Absolute indications: pneumothorax, hemothorax, and traumatic arrest. Relative indications: rib fractures and positive pressure ventilation, profound hypoxia or hypotension with penetrating chest injury. Placement may be diagnostic or therapeutic. Bright red blood suggests arterial injury, possible thoracotomy. Intestinal content can be from esophagus, stomach, diaphragm injury, intestinal injury, large air leak, bronchial disruption. Technique important to avoid complications. Insertion site of chest tube: mid or anterior axillary line behind pectoralis major, above fifth ribs. Since on expiration diaphragm rises, then high. Count down from sternum-manubrial joint, second rib. And on these pictures you can see how we can do it. Analgesia during chest tube insertion: painful, especially in muscle patients. Usually we give morphine or ketamine, 10-20 milliliters local analgesia, a long line of incision, perpendicularly through all layers of chest wall to rib below space, up into pleural cavity after aspiration air. Procedure: prepare and drape, incise along upper border of the rib, below the intercostal space to be used. Track is to the direct over top of lower rib, so as to avoid intercostal vessels lying below each rib should be big enough to fit finger. Use curved clamp to develop track by blunt dissection only. Used to spread the muscle fibers. Develop track with fingers. On reaching rib, clamp angled upward just above the rib, and dissection continue till pleural space enter it. And on these pictures you can see finger inserted into pleural space and air applicated. 32-36 French tube attached to clamp and insert a long track into the pleural cavity. Connect tube to underwater seal and suture in place. Examine chest to check effect. X-ray we use to check placement and position of this tube. Position dependent on direction of track. Blunt chest trauma patient lying flat, place drain anteriorly. Prevents blockage of tube and develop of tension pneumothorax. In case of penetrating posteriorly and basally direct drain, last hole should be inside the chest cavity. If too far, it could cause severe intractable pain when up against mediastinum. Underwater seal allows air to escape but not re-enter chest cavity. Negative pressure dependent upon level of water. Pleural vac must always be below level of the patient, and persistent butt line, air leak from lung. May be connected to suction, water level 20 centimeters, 8 lung re-expansion, especially if there is an air leak. Chest tube should never be clamped because will be tension pneumothorax. Chest tube removal. When we should do it? When no air leaks, no more fluid drain. How? Occlude hole while pulling tube. Remove at end of expiration or at peak of inspiration. Avoid air being drawn into cavity. Remove rapidly and close wound quickly. Complications of chest tube insertion. There is no organ in the thoracic or abdominal cavities that has not been pierced by a chest drain. Mainly, historically, since drain used to be inserted with a steel trocar axis force. Acute complications is hemothorax, is lung laceration, is diaphragm abdominal cavity penetration, is stomach colon injury, it's tube placed subcutaneously, tube placed too far, or tube fall out. These complications unfortunately can be in sometimes. Late complications is blocked tube with clot or lung, retained hemothorax, empyema, pneumothorax after removal or put technique. Conclusion. So chest trauma is a common, it's serious. Aim of the treatment to provide oxygen to vital organs, be alert to changes in clinical condition, manage most of the time with chest tube. Thank you very much for your attention. Wish you success and bye-bye.
Да, вот как раз они нужны.